Welcome back, ladies and gentlemen. The next segment is a guest lecture on role of physicians in the prevention of kidney stones. May I now call upon the chairpersons, Dr. Vasantha Disanayaka and Dr. Tushari Vanigaratna on stage.
Very much. Good afternoon, ladies and gentlemen. It's my great pleasure to introduce Professor Virginia Hood. She's a physician from Burlington, Vermont. Is a professor of medicine emerita, University of Vermont, and nephrologist at University of Vermont Health Network. She is the president emerita of the American College of Physicians and is the president of the International Society of Internal Medicine. Over to you, Professor.
Good afternoon, everyone. It's a great honor to be here, and I want to thank the organizers of SIMCON for giving me the kind invitation to present. And I'd like to thank the chairpersons here, Dr. Vasantha and Dr. Tushani, for their kind introductions. I'm going to talk to you this afternoon about kidney stones and kidney stone prevention, which is a topic that's of great interest to me, but I want to try to persuade you that it should be an interest to you as well as internal medicine physicians. These are my objectives. I don't have any disclosures. I would like to thank some of the great kidney stone physicians in the United States at the University of Chicago, who I have learned a lot from, and even some of my slides may resemble some of theirs, so I thank them for that. Let me go. So, why should you care about kidney stones? Well, there's a lot of it about. 1 in 2 people per thousand industrialized countries, 1 in 11 people in a lifetime have a kidney stone. It happens happens first in young people, but then it recurs. So if you've had one, there's a very high chance that you'll have another one. Kidney stones have a high incidence and obviously prevalence all over the world. What influences that? Well, geography. There are areas called stone belts, and you can see in this map here that Sri Lanka actually falls into one of those here, where places are either hot or especially hot and dry, and people have more stones. Climate change is influencing the rate of kidney stone formation. Genetic predisposition is a very important risk factor. People with a family history have a high risk of having stones. But the thing that we can influence is not where people live or how they are born, but what about their diet and lifestyle? And that's what we will talk a lot about today. One lifestyle trait that is changing is there are more and more people with metabolic syndrome, and these people have a much higher risk of kidney stones, both calcium oxalate and uric acid. Then, of course, there are changes in the gut and urine microbiomes, which influence everything in healthcare that we're only really starting to understand. Kidney stones have a high morbidity and cost. People who have one have a lot of pain, they have to have time off work, they have to have surgery, and this is all very difficult for them. Costs a lot of money to the healthcare system and to individuals, but you can save money by reducing recurrence, and that's what internists are good at. But another very important factor about kidney stones is that they're really part of a systemic metabolic disorder that involves vascular, kidney, bones, and gut. There's an increased risk of chronic kidney disease in those with stones, increased risk of coronary artery disease in women who have stones, and there's an increased risk of fracture. So this isn't just a few people with a few occasional stone. They have other problems as well that we need to address as internists. But the most important factor that I want to emphasize for you is that people who have kidney stones do not want to have another one. And while we say that nobody wants to hear from us about what we want to change in their diets, people who have stones do want to hear from us. Here are 4 people. I can't talk about them all, but we'll talk about a couple of them. Stones are mostly formed of calcium. 70% have that in them, but oxalate and phosphate as well. As you can see here, there are fewer people with uric acid stones, inherited stones of cystine, struvite or obstruction and infection. Most have calcium in them. Where do they form? They actually form in the medullary part of the kidney where the urine is concentrated, because that changes the relationship of the fluid to the solute and causes crystal formation. How do they form? Well, stones grow from crystals that are formed in supersaturated solutions. They're supersaturated with stone-forming elements, and they lack inhibitors. These are the things we need to know about. Supersaturation itself is influenced by concentration, too much solute, and by too little solvent, not enough volume, and also by pH. But crystallization is influenced not just by supersaturation, but by seeds and also by inhibitors. Supersaturation really is important because if we don't even know what a stone is, sometimes by knowing the supersaturation, we can have an idea of what the stone is that a person's forming. And supersaturation changes throughout the day, and it's higher at night. That's why we have to think about fluid and volumes in people at nighttime. And if we can lower supersaturation, we can reduce the risk of recurrence. But what we have to do is lower the elements that form the supersaturation. So what are those elements? The elements are too much calcium in the urine, which can come from too much calcium in the blood. People who have hyperparathyroidism or malignancy or other forms of that would give you high calcium in the blood. But that's a small, very small fraction. The most common reason for people to have too much calcium in the urine is because they absorb too much calcium from their diet. Now, they don't absorb too much, they don't absorb too much from their diet. They absorb too much from their gut. And it comes about because they may be taking excessive amounts of vitamin D or too much calcium as calcium supplements, which don't really help protect from bone disease. The other things that cause a lot of calcium in the urine that do come from the diet are too much protein in the diet and too much sodium in the diet, which I'll talk about a bit more. You can see them in these graphs here. What about oxalate? Well, too much oxalate getting into the blood and then in the urine is also increases the supersaturation, especially for calcium oxalate stones. Now, you might think that all comes from the diet, and some of it does, especially people who have suddenly changed from drinking dairy milk or taking dairy products and eating more almonds and almond milk and lots of nuts. A few are good, but more is not better, so you don't want to overdo that. They have a lot of oxalate, as does too much vitamin C, causing too much oxalate. But the most important reason that people have too much oxalate in their blood is because they have too little calcium in their diet. If you look at this picture, as you reduce calcium intake below about 1 gram a day, oxalate absorption increases. And this is the same reason that people who have short bowel syndromes or inflammatory bowel disease and have too much fat not being absorbed from their gut, it binds with calcium in the gut, and there's no calcium left to bind with the oxalate. So these people absorb a lot of oxalate and make calcium oxalate stones. Also, if we give people antibiotics, we change the gut flora, and some of those gut flora actually metabolize oxalate, like oxalobacter. And there, of course, are some inherited disorders that I won't talk about. The other factor that really affects the crystallization or the supersaturation of the urine is the pH. If you look at people here who have a pH of 5, these are people with a pH of 5, And these are people who form uric acid stones. If you can increase their pH over here to 7, you can almost tenfold increase the solubility of sodium urate or uric acid into sodium urate. With calcium phosphate stones, it's the other extreme. Low urine pHs are fine, but high urine pHs here are what causes the calcium phosphate supersaturation and crystallization. And so pHs greater than 7 are bad for both calcium phosphate stones and cysteine stones, but are better for uric acid stones. Calcium oxalate stones are less affected by pH, but too low a pH is not good for them either, less than about 6.2. What affects pH? Well, diet, medications, infection. I can't go through all of these right now, but I'll mention the metabolic syndrome again, because with the metabolic syndrome, the urine pH is often very low, about 5. So that's very bad for calcium, for uric acid stones, and not good for calcium oxalate stones either, the commonest form of stone. And it's probably because of insulin resistance. We're discovering insulin resistance does all kinds of bad things to the body as part of the metabolic syndrome. What about inhibitors? I said supersaturation is influenced by concentration, by fluid volume and solute concentration, and by pH. But crystallization is also facilitated by other substances. And one thing that stops the actual crystallization are what we call inhibitors. If you take a solution and put a supersaturated amount of calcium oxalate in it and wait around in a beaker of water, it will form crystals over about an hour. If you put it in the same beaker but in urine, it's very slow. And that's because in the urine there are inhibitors. What are those inhibitors? Some of them are these simple things like Tam-Horsfeld proteins, the things that form hyaline casts. Other things we can't measure, the pyrophosphates, and magnesium is important, and peptides. But the most important one we can measure and manipulate is citrate. And citrate complexes calcium, which stops it forming the crystals, just like it complexes calcium in the blood to stop it clotting. Citrate comes from the TCA cycle, but also from the diet. It's actually a base, but it doesn't alkalinize urine. But if you give people sodium citrate or potassium citrate, that's changed to bicarbonate in the liver and makes the urine alkaline. And we use that in certain ways to try, if we want alkaline urine, say for people with uric acid stones. About 20-40% of people have low citrate, and much of the time we don't know much about it. But those people who happen to have some kind of acidosis due to any form of systemic acidosis or intracellular acidosis like hypokalemia, they have low citrates because filtered citrate is reabsorbed in the proximal tubule in excess when in an acidotic state. So in summary of this first very brief part here, the relative risk of stone formation in women, here in red in a big cohort or case control and cohort studies, in men in blue, increase here you can see is more calciums in the urine, more oxalates in the urine, less citrates in the urine, and less volumes in the urine, and is also linked with supersaturation. So what do? So we have to sort of get a hold of all this. So we take a history, find out if people have any of these kind of problems. We find out what medicines they're on, particularly calcium, antacids, vitamin Z and C, and some of these other medications. We look at their diet, especially sodium and animal protein, how much fluid they're taking in, and especially are they taking their fluid in at nighttime when supersaturation is greatest and when stones can form. We want to know what the stone is made out of, and then we want to know what's happening in the blood and urine. So those blood tests are pretty simple. We just want to know if they have too much calcium, phosphorus, uric acid, potassium, or too little bicarbonate. In other words, do they have a systemic acidosis? And occasionally we might, if they have hypercalcemia, check for vitamin D or parathyroid hormone. But what we really want to look at is a 24-hour urine, because that will help us know what are the stone-forming factors and what are the stone-inhibiting factors, and what are the dietary factors people are taking that influence these. And remember that the urine in adults, we're in steady state. So what comes out in the urine in 24 hours often reflects what goes in or what's absorbed. And so we can tell a lot to patients about what they're actually eating or shouldn't be eating. So if we do a 24-hour urine like this one, and this is a series of several urines, starting with several months ago or years ago, and then up to the most recently, so that by the date, we can look at these things in a serial way and help patients understand. We can see, has their volume changed? We can see, is that urine collection the same every time by looking at the creatinine in it? Because creatinine should be about the same every time you measure it in the urine. We can look at how much calcium and oxalate, how much phosphate, how much uric acid. We can look at how much citrates in the urine and whether it's changing. And then are people eating a lot of salt in their diet? And from the urea nitrogen, how much protein they're eating. And then we can look at the supersaturations. So here's a man, he's 31, he's passed many stones over 5 years. His brother and father also have stones, and he was told that he should reduce the calcium in his diet, and he wants to know, is that the right advice? So if we look down here, we can see he has a lot of calcium in his urine, much too much, less than 250 would be good, or 200. And what can we do about that? So is there any evidence base for changing diet? Well, there's a very good evidence base for increasing volume from 1 liter to 2.5 liters. This was a randomized controlled trial a number of years ago, which showed about halving of the recurrence rate of stones. What about calcium? This was a very important study, again, some years ago, where they compared a low sodium and a low protein diet with a low calcium diet. And as it turned out, the people here who had 2 or more stones reduced the number of stones in their recurrence over 5 years by not reducing calcium in their diet, but by reducing protein and sodium in their diet. And in fact, those who reduced calcium in their diet had higher oxalate and continued to have stones. There were people who didn't respond. These were people with 5 or more stones, and they need some other treatment, which we can get to, and there is a couple of systematic reviews that you can get to. DASH style diet is also helpful because it gives adequate calcium, not too much protein, not too much sodium, and lots of fruits and vegetables, which give you citrate. Okay, so what did we do with him? We managed to put him on the DASH diet, more fruits and vegetables, got his sodium down, made sure he had normal calcium in his diet. And you can see here that his urine calcium went down there. His sodium went down and his urea nitrogen went down, which reflects protein intake. And sulfate reflects animal protein intake. So what about that group of people I showed you that didn't respond to diet, this dietary change? Well, have other ways we can reduce calcium in the diet, and there's always this talk about using thiazides because they decrease calcium in the urine, and they do. Citrates, as I mentioned, could be good if you have either too low a citrate or too low a pH. Allopurinol is good if you happen to have gout and stones and too much uric acid in your urine. But everyone thought that thiazides were the answer until a recent study was done called the No Stone Study. Here it is. It was published in the New England Journal last year. And it was a randomized controlled trial, 2.9-year follow-up, a large number of people, and people with 2 recurrent stones or more. And they used hydrochlorothiazide in small doses, 12.5, 25, and 50. And they looked for radiological recurrence, but they also looked for people describing how much recurrence they had of their stones. And they added all those together in one of these composite outcomes, which you should always be suspicious of. And it showed that when you put all that together, there was no difference if they took a thiazide or placebo. And if you just looked at them reporting stones, there was no difference. But if you actually looked at the radiological recurrence with CT, which was done very well, you could see in the higher doses of the thiazide, there was a reduction in the stones. And there were a lot of problems with this study, even though it was really a good study. There was some low power. The hydrochlorothiazide they used was a short acting, and in the prior studies, they'd been either long acting or used twice a day. And the diet was higher in sodium, and thiazides don't work well if you don't have a good lower sodium diet. And the symptomatic recurrence didn't exclude existing stones. So these were the old studies. You can see where they were using higher doses of the thiazides. I'll very briefly tell you about one more person. So my conclusion of the thiazide thing is you can use it, especially if you can't control calcium any other way. And it is important to do everything else first because it's not the first line of treatment. And it did cause lower potassiums and some lower citrates. Very briefly, another person is a 36-year-old with inflammatory bowel disease. He had stone removed from his left ureter, and he didn't want to have another one. And these are his findings. I'll just tell you, he had calcium oxalate stones. That was it. This is his urine. He had normal bloods, but he had a little bit, he had high oxalate. He didn't have high calcium, and he had a low citrate and a highish uric acid and not enough volume. So what can we do for him? We can increase his fluids. We can normalize his calcium because that will reduce the oxalate, and we can avoid excessive protein to reduce his stones and add citrate as an inhibitor. I won't talk about that. So in summary then, 2 to 3 liters a day because we want to have 2.5 liters of urine. We want to give people normal protein diets, 0.8 to 1 gram per kilo, normal potassium, relatively low sodium diets, normal calcium, lots of fruits and vegetables, and not too many supplements. And if that doesn't work, we can use thiazides, potassium or magnesium citrate, and allopurinol in some circumstances. And then we should monitor, look at this, because if we show this to the patients, they really like it, and they can see, I thought I was doing better, yes I am, or I need to change something else. Remember, nephrolithiasis is a systemic disease, and 24-hour urines can help us solve the problem. Preventing kidney stones, as I mentioned, is just a combination of diet and some other medications as needed. And having a dietitian is really helpful. And if you don't have one, you can get them on social media now. This is one woman, Bellany Metz, who works with the Chicago people. So we can prevent them. These are a few references. There are good podcasts around, and the Master Textbook of Internal Medicine, and I know there are some of your colleagues here who are part of the editing of that, also has a good chapter on kidney stones. Thank you very much.
Much, Professor Virginia Hood, for that very excellent and informative lecture. Due to time constraints, we'll allow one quick questions from the audience, if you have any questions. Okay, now, in the absence of questions, let's conclude this session. I will invite Dr. Vasantha Disanayake to hand over the Certificate of Appreciation on behalf of Sri Lanka College of Internal Medicine. Thank you very much.